Hello, I'm Richard Westerby from IV Fertility Services, and today we have the amazing Dr. Linnea Goodman from Virginia Fertility and IVF. Welcome.
Thanks so much for having me, Richard. Happy to be here.
So today I would love for you to do something that I've always struggled little bit with, which is understanding all of the acronyms, all of the things around fertility testing. What do they actually mean? So you test a male, you test a female, and you get different things. Can you maybe explain to me what is the testing, what are the acronyms, and what are the results?
Sure. So, one of the biggest things that people come to talk to me about, they come in and they say, I want to understand my fertility. And it's so different for every person. And so I have a subset of things I can look at for every person, but they don't mean the same things for each person. So we'll start with the menstrual cycle. So there's three things you need to have a baby. You need eggs, you need sperm, you need a place for them to meet. And so starting in the egg piece first, let's evaluate the woman, let's evaluate the menstrual cycle. So we have got three pieces to the menstrual cycle. We have the brain up here, which releases hormones. And then we have the ovaries down here, which then release subsequent hormones. And then the hormones that those release then act on the uterus. So the things that I can test for is I can test how well the brain is talking to the ovaries. I can test the ovaries to see their ovarian reserve. And then I can test the uterus to see how it acts as a host for a baby. So in starting with the brain, I want the brain to communicate with the ovaries really well. I want it to be a seamless, quiet communication that runs in the background. So in the beginning of each cycle, the brain releases the hormone FSH. And this FSH's job is to gather the troops of the ovaries. And every month we create this group of eggs. And of this group, one becomes dominant and the rest of that group dies off.
So what does FSH mean?
So FSH is follicular stimulating hormone. And this is the crux of rallying this group of follicles. And so if it's running well, it's kind of like a kindergarten class and you have a kindergarten teacher. And if it's going well, the teacher says, hey, guys, it's time to go. And all the kids sit down and listen. And they say, good, we're ready to learn. If you have an unruly class, then the teacher has to yell at the kids. And it's like, come on, let's go. And the kids are like, I'm not listening. And so that would be, for example, PCOS, where we are yelling at a bunch and it's just not working.
PCOS?
PCOS is polycystic ovarian syndrome. And this is something that gets dysregulated and people stop ovulating with. And so as we get older, we have less in that group of follicles, less in that group of eggs. And so now the brain starts screaming at the ovaries. So the FSH starts to rise. So a good FSH value is less than 10. And that tells me that the brain is communicating with the ovaries. As we get older, our FSH starts to rise to yell at the ovaries. And if there's not a lot of eggs, it starts screaming. And it's like, come on, let's go, ovaries. And the ovaries like, I don't have anything to give. I've got nothing coming up. And so as we get closer to menopause, that FSH starts to get higher and higher. Now, FSH is difficult because it changes month to month, because it depends on how many eggs you have available. So 1 month it could be fine, and 1 month it could be high. And so FSH is really not super important in my evaluation, except if I'm worrying that someone is running out of eggs, or if I'm worried that the ovaries are not responding for another reason. So really FSH is my least important parameter.
But would you test it more than once? Would you do like 1 month after another just to see if it's the same or changes?
Yeah. So honestly, I don't test FSH on most of my patients. The biggest time that I test for it is when insurance requires me to do it. So some insurances, in order to pay for the fertility treatment, will require day 3 estrogen and FSH labs, which we'll talk about in a second. But this doesn't really help me in a clinical sense.
Okay.
It just says that this woman is not yet in menopause. Her brain is not yet screaming at the ovaries, which really happens when we start hitting our late 40s, early 50s. What's really important is the lab test called AMH, anti-Mullerian hormone. And so basically, I've got the brain making FSH, talking to the ovaries. The ovaries are bringing up this group of follicles, and each of these little developing follicles is secreting this hormone called anti-Mullerian, AMH. And so the higher your AMH, the more eggs you have. And so that tells me how many are in this group that's coming up. It doesn't tell me how good the eggs are or about this dominant one that's going to come up. It just says that I have a lot in this group. This helps determine how you respond to my IVF medications, which, going back, is FSH. So I'm testing your FSH. I can give you more FSH and you're going to make more follicles. So why AMH is important is it tells me how much gas is in the gas tank. Now, it doesn't tell me how you're going to drive. You might be driving around with a full tank of gas and I'm driving around with a half a tank of gas, but we're going to go drag racing. We're both going to do the exact same. Same thing with my follicle. Quality does not matter with quantity. They do not correlate. And so quality and quantity both go down as we get older. And for some people, they are very much correlated. But for a lot of people, you can have a lower quantity and still have good quality. And unfortunately, there's no good test for quality other than age. I wish I had some parameter. If someone out there can find a parameter that tests for egg quality, I would love that. That's probably the biggest question I get. But so AMH can help me to determine A, how are we looking at it in our gas tank? And B, how are you going to respond to my medicines? And what can I tell you about fertility treatment that is going to then ensue, specifically IVF?
The AMH level change every month?
Great question. And the answer is it does fluctuate some because it has to do with that group that's coming up. And that group will be more or less, but it will stay usually within the same range and it will decrease over time. So if you test it 1 month, so a normal value is between 1 to 8. So you could be 1.7 and the next month 1.6, the next month 1.9. And that's not saying that your egg count has gone down and then up. It's really kind of staying in that same range. Now, however, you can have different times in your life. For example, when you are suppressed on birth control pills, sometimes we see a lower AMH. Or if you have damage to the ovary, you have surgery on the ovary, it can be sometimes you can damage it permanently, or it can be suppressed and then rebound some. And you can see that with surgery, you can see that with chemotherapy, different things that damage the ovary.
Okay, so we've done FSH, follicular stimulating hormone. We've done AMH, anti-Müllerian hormone. What else is there?
In the beginning of the cycle, we have the brain that makes FSH, which talks to the ovaries, which then bring up a group of eggs. We then have a dominant follicle that makes estrogen. So estrogen then feeds back on the brain and says, brain, I've got my puppy. I don't want a litter of puppies. So then the FSH drops. And when the FSH drops, the rest of those little puppies, they die off. So this dominant follicle that's now been created starts making estrogen. It starts below 75 or so. It then starts rising to a level of about 200 at the middle of the cycle. And now this sustained estrogen talks back to the brain, to the receptors in the brain, and it says, hey, I've got a mature follicle. It's time to ovulate. And so the brain then responds by making LH. So that's the other hormone, luteinizing hormone. You have a surge of LH, and people are familiar with this because that's what you check on ovulation predictor kits. So that's when you pee on the stick in the middle of the cycle, you'll see that surge, and that surge stimulates that follicle to rupture and that egg to come out into the fallopian tube.
So LH is an indicator of the fact that you're about to ovulate?
Exactly right, about 12 to 36 hours later. LH values, so getting a random LH value is not super helpful, but seeing your LH surge can be helpful to know that you are in fact ovulating.
So if you're doing this at home with home testing, it's a good way for you to be able to predict when you're about to ovulate in case you want to then try to have a baby naturally.
Absolutely. And so then after you ovulate, so we've got that follicle's ruptured, that follicle then involutes on itself and becomes what we call a corpus luteum. And that corpus luteum starts making progesterone. So that progesterone, I like the value above 3. That means you, yes, in fact, did ovulate. Now, this is what also makes your temperature rise. So when you have progesterone, the temperature rises. A lot of people come in and they've been checking their temperature in the second half of the cycle, and that confirms that they did, in fact, ovulate. That corpus luteum, that involuted cyst that makes progesterone, lives for about 12 to 14 days. And then you get pregnant, that pregnancy makes HCG, that HCG talks to your corpus luteum and says, corpus luteum, don't die. I don't want you to die. Keep making progesterone. Or if you don't have that, it's a ticking time bomb and it explodes and it dies and you lose your progesterone. And so this is important because remember we talked about we've got the brain, we've got the ovaries, and now we have the uterus. So the brain and the ovaries are super smart. The uterus is not smart at all. So the uterus just takes direction from the hormones. So in the first half of the cycle, when it sees estrogen, it builds this nice thick lining. And then once it gets progesterone, it builds glands and stabilizes the lining, makes it a really great place for implantation. And then once you lose progesterone, that tells the lining to shed and you get your period.
Fascinating.
And so that's the menstrual cycle in a nutshell.
Wow. Okay. So you can test FSH, AMH, LH, estrogen, and progesterone.
Correct.
So you can do those 5 tests in a woman to be able to see where they're at, how the whole thing is going.
And that's the egg piece.
That's
so we
the
talked about
egg
there's eggs, sperm, place for them to meet.
Okay, fine.
That's
so
my egg piece.
So now let's talk about sperm.
If you remember back to those memes where it shows the woman and there's all the switches and the buttons and everything, and there's like a million of them, and you go down to a man and there's like a light switch.
Yep.
That is how fertility testing is. It's crazy. For the women, we have so many different things. For the man, we have the semen analysis. And this is a little antiquated because there's a lot more that goes into it. But I think it's because it's the hammer and the nail. There's only really one thing we can do about it. And so we really only do one test, and that's the semen analysis. Within the semen analysis, there's lots of different parameters that we look at. Really, there is one that is the most important to me, and that is something called a total motile count.
Okay.
And that is the number of moving sperm in the sample. I like that to be about 20 million. And so to get that number, we get a concentration. So that is the amount of sperm per milliliter. We then get a volume to get your milliliters, and then we get a percent motility. And that can be differentiated down into progressive motility and different variables, but really all I care about are the sperm that are moving in that sample.
So a question, going back to what we've just done on the eggs, that's all done by blood draws, scans, or how is that all done?
Yeah, so every one of those are a blood test, and AMH can be done at any time in the cycle. FSH is done on day 3 of the cycle. LH oftentimes will be got at the beginning of the cycle, but is more helpful in the surge. Progesterone is on day 21 of the cycle. So different time tests during the cycle.
During the cycle. So on the sperm, you're not going to test within the testicles. The man's going to ejaculate, and then you're going to look at what is produced.
Correct. And oftentimes we can do that at home. So he can collect it at home and bring that in. And we like that within an hour.
Okay.
Or collect it in the clinic.
Okay. And so that would just be looking under a microscope, I guess.
And it gets counted in a little Geiger counter that takes a little area and then extrapolates it.
So you've got somebody literally counting 1, 2, 3.
Literally. Not up to 20 million. But, like 17 times however much there is.
Okay, so you're looking at the total, I love it, the total motile. That sounds like a cartoon. The total motile count. So that is a combination of...
That's your concentration. So it's the amount of sperm and the amount of moving sperm. So the amount times the motility.
Okay.
We also look at shape, which is called morphology. This is my least important parameter. I'm not quite sure why Mother Nature decided that we needed to have 20 million moving sperm per ovulated egg. It doesn't make much sense. And so in that vein, a normal morphology, a normal shape, is considered greater than 9%. On some assays, greater than 4%. It depends on which criteria you look at. Different clinics are different. But so that's 91% of sperm being abnormal. And by abnormal, I mean 2 heads, 2 tails, weird shaped, funny looking sperm. It's very strange that Mother Nature decided that 91% of sperm being abnormally shaped is normal.
The majority of sperm is abnormal.
Correct. And, I think of it kind of like spaceships. So the sperm itself that we see when we look in our microscope is a spaceship. The DNA inside are my astronauts. And so we have this huge amount of spaceships that take off, but some of them are like super weirdly shaped, and some of them only have 1 rocket, and some of them don't even have a windshield. And so all of these guys are crashing into each other. The astronauts are fine. The DNA inside is fine. But the ones that can move straight, those are the ones we want to get to the moon. And so that is what we're looking for, is we're saying, okay, how many little spaceships out there are on a path that can get to the moon?
Okay, so the male testing is pretty straightforward.
It's very straightforward.
Okay.
Now, should it be abnormal, then there's further testing that a reproductive urologist can do. They can do an exam. They can do the same testing that the women get. They get hormonal panels and go through that as well.
And will hormones affect sperm?
Absolutely, they will. Women have FSH, which talks to the ovaries, which make estrogen and progesterone. Men have the same things. They also have FSH and LH, which then go make testosterone and sperm. And so one of the biggest things that men don't realize is that if you are taking testosterone, it then feeds back to the brain, just like estrogen feeds back to the brain, and stops the brain from making FSH and LH, which then stops sperm production.
So testosterone supplements are bad for sperm production.
Correct.
Wow. So if you're taking testosterone supplements, beware. It's not good for your sperm. So we've done sperm, egg, and then the place for them to meet.
Place for them to meet. So that's the uterus.
Bar.
The bar. Or online these days.
Online, exactly.
So, or through a friend. So what we're going to be doing to look at the uterus, we have a couple different ways to look at the uterus. And ultrasound is our primary method. And then a hysterosalpingogram is another test.
The what?
You have a hysterosalpingogram. So that is an acronym HSG. So that you'll see that all over the place, HSG. And what these tests do, they're a little bit different. So ultrasound looks at the uterus and looks at the ovaries. And when it looks at the ovaries, it gets what we call that antral follicle count, an AFC. That's another way of evaluating kind of how many little eggs that we can see. The ovaries look like a chocolate chip cookie on ultrasound. The more chocolate chips you have, the more little follicles you have.
And this ultrasound is with the gel on the belly, and you're doing it this way?
It's a transvaginal ultrasound.
Which means what?
Which means that the ultrasound is an internal ultrasound. It goes through the vagina to look. It's the closest way that we can get to the uterus and the tube.
So it's an internal examination.
Internal exam. And for people that haven't had one, most of the time it's not painful at all. There's a little discomfort. And it gives us a really good sense of what the uterus and the ovaries are doing. Unfortunately, it does not give us a sense of the tubes. And that is a key feature of getting that egg and the sperm to meet, because they actually meet in the fallopian tube. And a lot of people think that the fallopian tube is attached to the ovary. So we have the uterus here, we've got our tubes here, we've got our ovaries here, and they're not actually attached. So the ovary here makes its little follicle, it ruptures, the egg gets released, and the tubes will then float around with these little vacuum, these little fimbriae on the end, and literally suck up that egg.
I'm sorry, back up a sec. At school, when you're learning about biology, they're attached.
That is correct. The models, the hard models that you learn, they are attached. That is not the way in the human body how it works. And so they're floating around, and they grab that egg. The egg travels into the tube. The sperm then travels up the vagina, into the cervix, into the uterus, comes into the tube. They meet in the fallopian tube. They actually spend 5 days traveling down the fallopian tube into the uterus and then implant in the uterus. And so the test that we do is called that HSG, that hysterosalpingogram, where we put dye into the uterus and watch it spill out through the tubes. Now, this one can be a little bit more discomfort because we are actually putting dye into the uterus. But it's quick and, usually takes between 10 and 15 seconds. And we get a really good sense of the uterine contour, the shape of the uterus, if there's things in it that block the egg and the sperm getting together, and making sure that those tubes are nice and open.
And then maybe a bit of a gross question, but what then happens to that dye? Do you just pee it out?
Yeah, it's a great question. It actually spills into the belly and then is absorbed.
So you don't pee it out?
You don't pee it out. I mean, I guess in some cases you absorb it and then it goes through your kidneys. But
yeah, but it's not like you put it in and then it just drips out.
No.
Okay, cool. Again, these are I'm learning so much. So if I'm still you have this thingy going around, how does it know where the egg is?
It's a great question. I don't know the answer, honestly. I think that it has this ability to sweep through.
I love the tentacles.
Yes, the tentacles. and then it just, when it finds it, I think it's kind of like probably a little Velcro ball and some Velcro tentacles that it attracts through, my guess is proteins or some sort of enzymes that have some sort of attraction to each other. And then it comes in and then in the tube, there's these things called cilia. And the primary thing that messes with this cilia is infection, primarily chlamydia and gonorrhea.
Okay.
And so those can damage these little hairs, just like the hairs in our lungs. We've got cilia in our lungs, we've got cilia in the tubes, and these guys gently sweep it down. And when you have chlamydia, it damages these cilia, and the egg in the tube can get stuck, and you can get a pregnancy in the tube.
Which is an ectopic pregnancy. So always get your STI testing done. Um, and you've said something that actually I think is really interesting. So you said it takes 5 days generally for the egg and the sperm to meet and then to travel down the fallopian tubes. Is that why in the laboratory you're incubating for 5 days?
That's exactly why. So we used to do day 3 transfers because we weren't very good at growing embryos. We actually, back in the day, we did day 2 transfers. That's the way back, throwback. And then we did day 3 transfers because we knew that we could grow to an 8-cell embryo in the lab. And then we started realizing that we could grow them out till day 5. And at day 5, they were blastocysts. And these all came from studies looking at cadavers that had ovulated or hysterectomy specimens. People had removed the uterus, and then they'd said, "Oh, you ovulated 5 days ago. Let's go find where that egg and sperm would be." And so they dissected it open. They're like, "Oh, it's weird. We're 5 days in, and it's still in the fallopian tube." And so when we started doing day 5 transfers, our success rates were so much better because that is when the uterus is ready to receive the embryo.
Okay, so with the testing, to recap, is the woman is going to be able to do FSH, LH, AMH, progesterone, estrogen. The man is going to be able to do basic test, and then you're going to test the uterus and the fallopian tubes.
Exactly.
Well, thank you for that. That's super interesting.